Well, good evening, everyone, and welcome to the third Sleep Medicine in the Era of COVID-19 webinar. I'd like to welcome you, and I hope that all of you see my slide. Okay, now let me introduce myself. Mohammed Al-Houqani, I'm Associate Professor at your university, and today also I'd like to welcome my colleagues who will also present after me. Dr. Fabrizio Faccini, who's a consultant pulmonologist at Radiant Clinic and Hospital, Dubai, UAE, who will be talking about home sleep testing. Then I'd like Dr. Hisham Hamdan, who's a pediatric pulmonologist and sleep medicine at Al Jalila Children's Specialty Hospital, Dubai, who will talk about the home non-invasive ventilation for pediatrics. And last but not least, as our guest speaker, Dr. Saeed Al-Kabi, Head of Neuromodulator and Sleep Disorder Unit at Al-Masarra Hospital, Muscat. And that would hopefully every speakers will spend 20 to 25 minutes, and we will allow 5 minutes after each talk for question and answer. And if you allow me, I'd like to start my presentation, sleep medicine in the age of COVID-19. Okay. So, as you know, December 19, there was the first case identified of coronavirus causing the acute respiratory disease that was in Wuhan. By January 30, WHO declared a public health emergency on international concern. March 11, 2020, WHO declared it as a pandemic, and on March 19, the American Association of Sleep Medicine had some recommendation of limiting testing. Today, as of June 28, 2021, we have a total of 181 million cases and 3.92 million deaths. So this really affected the sleep medicine practice. And during my next 20 minutes, I'll talk where are we now and where are we headed. So there were multiple statements by professional societies, started by ASM back in March 2020. The Australian Sleep Society followed, the British Thoracic Society, the Canadian Thoracic Society, ATS, and ERS. And it's all about having a safe practice for both the technician, physician, and patients. Now, all these did affect the function of the sleep labs with early shutdown, approaches to screening and testing, the personal safety for technologists, triaging, and the fitting and education. There are many staff technologists who were redeployed to other highly needed area. Respiratory therapists, as you know, many of them are sleep technology. Many of the sleep technologists has a background of respiratory therapists. They moved to ICU settings. Also, physicians were redeployed and transitioned to telemedicine. Now, there are many changes in sleep lab activity. You see one of these studies that showed the prior COVID-19 and during COVID-19, where the percentage of sleep testing went down from 92% to 20%. So we're talking about drop of 70% on testing. Now again, there were many mitigation strategies during the lockdown. Many sleep labs had moved to virtual visit only. Some of them, very few, I see here, that had no limitation. Some of the labs inside the hospitals, and we have examples here, where it was the hospital were basically moved to be a COVID-19 centers and the sleep lab has closed. Now, The AASM COVID task force had put some recommendation, which I will go through in the next few slides. It's again is about the safe practices and using of appropriate PPEs at all times, the hand hygiene and avoiding unnecessary personnel in the centers, and consider all meetings with team supervisor on a virtual platform. And if there's a positive case, it should be informed immediately and assist in contact tracing. Everyone and all personnel should be vigilant to their, again, precaution, not only during their work, but also outside work. There are many studies that showed most of the healthcare workers are getting the COVID-19 from outside work. So we do encourage the safe practices outside work and promote the factual information and encouraging vaccination and avoid large gathering. Now, again, there's enough data that showed reduced sleep efficiency would increase the nightmare in healthcare worker. So the sleep duration and sleep efficiency independently associated with frequent nightmares and after adjustment for age, gender, and poor mental health and regular sleeping medication use. Vaccination is important. We need to encourage all the staff, patients to be vaccinated. Every time my patients come, we need to ask them about the vaccination, do encouraging and offer education. Encourage also healthy sleep habits before and after vaccination. And we do have enough evidence that really healthy sleep does improve the immunity. And there are some data that showed even a surge and improve in response to the vaccination, whether it's flu or the COVID-19 vaccination for people who had a good sleep even before having the vaccination. To continue the mitigation strategy, I always advise, even if you got your vaccine, even if all the staff are vaccinated, we should continue using the precautions, having all our full PPE, especially during the titration study. Now, COVID-19 testing, it's all depending where you are. Again, at least here in my city, every health professional should do COVID-19 testing every 2 weeks. Now, there should be also screening for the staff when it comes to symptoms. So we are screening our staffs and patients before coming to the sleep lab. Patients' communication is really important, and there are many patients who had fear of COVID-19, and this should not become a barrier in the standard of care of non-COVID disease. So we need to communicate with our patient and explain to them that delaying need care increased medical risk. COVID-19 transition to patient in healthcare setting has been very low comparing to their social gathering. Convenient options are available using a telemedicine, even if it was a simple phone conversation. And if you don't have the full technology, it still can do most of the work. Getting sufficient sleep before and after vaccination may also help to optimize the immunity, and healthy sleep is essential for health and well-being and safety. Now, sleep apnea as a risk factor for COVID-19 mortality, a study was done retrospectively looking at medical records and showed an increase in all causes of mortality, a rate of 11.7% compared with control, with an odds ratio of 1.79. So there is really a link here. Now, another study is a meta-analysis that showed the obstructive sleep apnea and relation to severe COVID with hospitalization with odds ratio of 2.37. So clearly obstructive sleep apnea is independent risk factor for severe COVID-19. And this comes with multiple things, patients with severe obstructive sleep apnea, they're also obese, and they have also risk of diabetes mellitus, which is also a risk factor for severe COVID-19. And as another meta-analysis that looked at 21 studies, a total of 54,000 patients, that showed obstructive sleep apnea associated with poor composite outcomes with odds ratio of 1.7. We're talking about more ICU admission, mechanical ventilation, and mortality. There's also a psychological impact of COVID-19, which I will not go through because Dr. Saeed Al-Kaabi will talk about the impact of COVID-19 on insomnia and the psychological impact. So scheduling patient post-COVID-19 infection is really safe if the patient is having a mild disease and after 10 days, if they're symptoms free. Here at least we're doing another PCR to ensure that they're negative, but the ASM said after 10 days with symptoms free, they should be fine, and if they're severe illness, it should be at least 20 days after symptoms onset. What about sleep testing? Now, if you have a surge in your city, you need to consider a home sleep testing, and we have Dr. Fabrizio who will be talking about the home sleep testing. There's an update from ASM that quarantine for 72 hours after recipient of the home sleep testing device may no longer be required, as a major route of transmission is airborne. Like last year, we thought that all the devices should be left and not used for 72 hours after disinfection, but clearly now this is not the case and you could continue using. And most of the items on the home sleep testing are disposable anyway. Now, what about the in-lab testing? It's a case by case. Again, so there's some complicated patient would require coming to the in-lab testing. And in US, the CMS currently allowing prescriptions of positive airway pressure devices based on clinical assessment. With titration, we need to know that CPAPs and BiPAP are considered aerosols generating procedures, and therefore we should conduct it in a full PPE measure for airborne disease and should be in place with terminal cleaning of the room post-study. And here I'm showing samples of the CPAP, BiPAP mask filter that received an emergency use for authorization by FDA. Unfortunately, these you can make your own, but not available anywhere. Well, at least here, it needs to be ready fitted with different pieces. I should say it's not commercially available here. So, but what we need to ensure that if we do the titration, we need to protect both the patients and our staff with a full PPE. Now, should patients who are having COVID-19 use their CPAP at home? Well, it's a balanced risk for going therapy versus continuous of therapy, depending on the severity of the disease and the comorbidity. And I always say, if they're having their own room, if they can isolate themselves, it should be fine. What about using a humidifier? ATS and ASM guidance does not suggest foregoing humidification through emphasis approach of cleaning. But the European sleep expert paper suggests that using the humidifier is not indicated under such circumstances because it does increase droplets and aerosols generation. We need to continue educating our patient of using the PAP devices at home with daily cleaning, using distilled water for the humidifier, and sleep in separate space. Now, we do have evidence that patients during the lockdown did increase home CPAP use. This is at least from the French cohort, where basically they compared 1 month before and 1 month after the lockdown, and there was an increase of around 44% in the adherence of the CPAPs, and year to year, an increase of CPAP of around 4.4%. And there is a proportion of a very low adherence of less than 10 minutes, which has been dropped by almost 18.5% between the similar period in 2019 and 2020. So it's really basically my advice to all my patients: continue wearing your CPAP, but also keep cleaning it and following up with your physician. And if you have COVID-19, ensure that you're isolating yourself so that you're not spreading the infection to family members. Now, where are we headed? So with the first wave that unfortunately were across the world, we will all concerned about the immediate mortality and morbidity of COVID-19. With the second wave, we are more into the impact of resource restriction on urgent non-COVID-19 condition. And a third wave, we're talking about patients who had interrupted care on their chronic conditions. So what we need to do here with post-pandemic is thinking about a way like sleep telemedicine to ensure that there is no interruption of care for chronic conditions such as obstructive sleep apnea. So I think there will be a huge role here for both telemedicine, telemonitoring, education, virtual education, more home testing comparing to PSG, and a high value care. We are looking for more integration of novel data where patient at home can also send data related to their PP reading, oxygen saturation, EKG, maybe some lung exams, and mobile PSG. And I think this is coming soon. Now, what about the telemedicine? And again, here I'm showing you some estimated percentage of virtual clinic visits before and after COVID-19. And there's clearly an increase in the use of telemedicine after the COVID-19. Education, many of the educations that we're doing in the clinic, including the CPAP adherence, the cognitive behavior therapy for insomnia, can be done actually virtually and does not require patient to come in person. So I would think that more than 50% of our activity can easily move to telemedicine and virtual education and monitoring. What about home sleep testing versus BCG? So the pandemic has only accelerated the use of home sleep testing. The sleep laboratory is increasingly going to be reserved for more complicated patients, and the field needs to be able to show where the in-lab study provide additional value outside the supporting of non-obstructive sleep apnea and non-narcolepsy diagnosis. I'll stop in here, and I'd like to thank you, and we have 5 minutes, or maybe less, for questions. I would say 2 minutes per question. Now, if you have a question, you could write it on the chat, or question and answer actually here. Okay, now I have a question here. Is snoring a very bad sign for COVID-19 positive case? This is from Dr. Nawal. I would say many of patients who had COVID-19, it comes with also inflammation of their throat, as you know, and upper airway, and there's a risk of snoring. Well, we need to know that not every snoring is obstructive sleep apnea, and there will be in a disadvantaged position to do a sleep study. Now, if they have a background of obstructive sleep apnea or symptoms of obstructive sleep apnea prior to COVID-19, yes, that would be, according to the studies that I presented, that would put them at a higher risk of hospitalization and complication. Now, There's another question. How is oxygen saturation critical limit for these cases? Well, I'm not sure about the question, but basically oxygen saturation for obstructive sleep apnea, as you know, it goes up and down, and this is really causing endothelial damage and more inflammation. And that could be why many of them are at higher risk of hospitalization. Okay, so I'll take one more question. Okay, this is maybe not related to this talk, but someone is asking what precaution after removing the tracking device on the day 10 after a mild symptoms of COVID-19, do we continue home quarantine? No, here we don't continue. So after 10 days of no symptoms and a very mild, we don't continue a home quarantine. But again, it's every health authority has its own guideline, and you need to follow your guideline in your local area. How much help CPAP provide is a case of sleep apnea and COVID-19? I did not understand this question. How much? Okay. Dear doctor, good evening. With asthma, risk of sleep apnea? Okay. Is asthma risk for sleep apnea? Well, the many studies that were done, it's not really clear, but if they comes together, if sleep apnea and asthma comes together, that would put asthma in a more severe cases. And CPAP does help against severe asthma to manage overall the asthma if it comes with obstructive sleep apnea. And again, the worst part is if it is obesity, hypoventilation. I think I took more than my time. I'd like to thank you all. And this is time to welcome the second speaker, Dr. Fabrizio, who will be talking about home sleep testing. Thank you all, and looking forward to listen to Dr. Fabrizio.